Yeah. Good morning to everyone. Welcome to another session of Pediatric CME. Today we have the Pediatric Surgical Department presenting Pediatric appendicitis, an approach to acute appendicitis in pediatrics. So we have Dr. Ali Sami, who is our resident in surgery. He will be presenting the initial part, and then Dr. Mahmoud Abbas, our consultant pediatric surgeon, will take on the second half, right? So I hope this the CMA is useful to all of us because we very often encounter cases of suspected acute appendicitis. So it will be a good learning experience for all of us to go through this from the pediatric surgeon's point of view. Thank you so much. Over to you, Dr. Sami.
Okay, thank you, Doctor. Good morning, everyone. This is Dr. Ali, JP Doctor. I am in attachment with Dr. Mahmoud Abbas in Pediatric Surgery Department. Today, I am presenting pediatric appendicitis in the Emergency Department, identification and evaluation. So when we are talking about our objectives for today is to see the both typical and atypical presentations of the appendicitis and the variations in the children depends on age and other also groups. We want to differentiate appendicitis from other causes of abdominal pain between two brackets, the differential diagnosis. At the end, we want to have a kind of approach to see a variety of diagnostic tools. When you are starting about the appendicitis, as we all know that appendicitis is one of the most common indications in emergency abdominal surgery. It's 1% to 8% of children presenting with abdominal pain in ER. So 5% of children diagnosed with appendicitis are 5 years of age or less. We will talk about this in another slide about the age variation groups. Males are more common to get appendicitis than females. For the advanced disease, when we are going in a progression of the disease, the younger patient who will have more than from 5 years to 12 years, 57% to develop complications. Successful and accurate diagnosis for appendicitis have been reflected by the balance between perforation rates and rate of the negative appendectomies. We will talk later about the perforation rates because perforation rates will raise for us, less for us the negative appendectomies. We are not taking a patient, especially the pediatric patients, to OT. The reported rates for the perforation vary significantly by age is. In the neonates, it's 50 to 85%. So this is the rates to get perforation. And in young children below the 5 years, it's 51 to 100%. And the school age, it will be less with 11 to 32%. And for sure, for more than 12 years, it will be 10 to 20%, which is less in this age groups. When we are talking about the pathophysiology of the appendicitis, shortly and briefly, we start with luminal obstruction, raising the intraluminal pressure, getting a secondary bacterial infection. Then at the end, it could be necrosed, perforation, and the patient could get into an abscess, intra-abdominal peritoneal abscess, and then we get the shock and all the stuff. So what we want to do today is we want to set a way to avoid getting the patients, especially the pediatric patients, which have a less time than adults to get into the necrosis and perforation stage. So, and this is the aim of our presentation today. Disease course, when you are talking about a pain evaluation or pain evolution, the pain starts early in the periumbilical areas. Then it will merge to the right lower quadrant, as we all know as a typical presentation for the appendicitis. For the disease progression, it's get worsened in 24 to 48 hours. So the ongoing obstruction can get perforated within 48 to 72 hours. And these hours, we are talking about the pediatric patients only, not adult patients. So yeah, in younger patients, the perforation could be early than this also. So the more the age is less, the more is the perforation rate, as we mentioned before, is more, and the more that the time we have to save the patient and avoid perforation will be less. That's why in our presentation we are talking about how can we detect and highly suspect that this patient in ER is getting an appendicitis, which is will be challenging in this age and these groups. Clinical manifestations. So on diagnosing appendicitis in children, it will be challenging, as I mentioned, because the typical symptoms and signs are often not present. We will mention the typical signs later also. And the clinical findings frequently overlap with other conditions. So yeah, uh, patient in ER with appendicitis could be present with what? This, we can talk about a typical or classical presentation, and we can talk about an atypical presentation in ER. A typical presentation, as we all know and read in books, it's periumbilical pain, goes to the right lower quadrant, having anorexia, nausea, patient will have a low grade of fever, vomiting sometimes, but after the pain. And the most important thing is the pain will be in the right lower quadrant, which we will call it in another term, a McBurney point. Near the McBurney point will be 1/3 one in the right lower quadrant. After talking about the typical presentation, which we all know, we should talk and mention about the atypical presentation, and we should focus on it. Why? Because if a patient appear with a typical presentation, present for me in ER with typical presentation, it will be easy to detect appendicitis. Then we will move forward to the management of it. But if patient appear with atypical presentation, this maybe be confusing and maybe be misdiagnosed. So patient with appendicitis can present with left lower quadrant pain, not a right lower quadrant pain. Can present with a flank pain, can present with pelvic pain, can present even with diarrhea, can present with suprapubic pain. And that's all depends on the location of the appendix. So if it's a long appendix, it can present with the left lower quadrant pain. If it's a retrocecal appendix, it can present with a back pain. If it's a pelvic appendix, we will have a pelvic pain. So different in presentation of appendix, different location of appendix inside your body, inside the patient body, sorry, can have a different kind of a presentations. Here is a photo of the positions of appendix, going from the most common to the least common, starting with retrocecal, which is 65% as a most common presentation. And as we mentioned, sorry, can I go to the previous slide? Oh, okay. As we just mentioned, that the flank or back pain can be can a patient with appendicitis present for it if you have a retrocecal appendix. Oh, I think Okay. And for the pelvic, for example, and on the right side, you will see the retrocecal area, which will be behind the cecum, and the peri and post ilial, pelvic, sub and paracecal or subcecal. We have another also, maybe the photo didn't mention, we have another presentation or position for the appendix. We called it subhepatic appendix. So patient with subhepatic appendix could have a pain in right upper quadrant, and this could be confusion, a big confusion with other as the hepatobiliary diseases. Okay, so patient with appendicitis, this was the typical and atypical presentations for them. We could have also an associated symptoms as anorexia, nausea, low-grade fever, constipation, abdominal distension. We can have also shivering or rigors. Age-related variation. So as I mentioned in the epidemiology part, a young children below the 5 years, the appendicitis will be less in this age of group. And the age of group from 5 to 12 years, sorry, appendicitis is more common in these groups and more likely to get a classic presentation. So about the typical presentation we just mentioned now, the age group of below the 5 years, pediatric patients, is more likely to get a typical presentation of appendicitis in ER, which will be more challenging in diagnosing the patient, especially with the short time of limit, because as we mentioned before, the perforation rates for the below 5 years patient group will be more. And this some anatomic features of the appendix may play a role in the incidence and presentation of appendicitis. Uh, the first years of life, appendix will be funnel in shape, will be making it less like to get obstructed and then to get a secondary bacteria, to get appendicitis between two brackets. The omentum is thin as well, which can account for the diffuse peritonitis, will be more. Why? Because the unwell development of the omentum, okay, cannot successfully seal the appendicular, okay, which will lose the perforation rate as well. That's why the perforation in children will be more, especially in the lower ages. Lymphoid follicles as well, which can also increase, which will be inside, will increase also the maximal size during which will get the maximal size during the age group of 5 of 12. As we mentioned, below the 5, this will be in a development part, so this also can get more obstructed and getting the appendicitis. Let's move on to the physical examination. We talked about the clinical symptoms, presentations, typical, atypical, and the causes for the appendicitis in ER. Now we will talk physical examination, which will help us to evaluate the patient. This is important. We should get a general observation, especially it's hard to get with the pediatrics to get the history, to examine them. Sometimes they are not helpful. Okay, so yeah, children with appendicitis will avoid movement. He may have a hip flexed. Okay, he will flex his hips sorry, the legs. A child who's jumping, playing, moving comfortably is less likely to have peritoneal irritation. So this should be considered. Abdominal palpation, which is the most important point in physical examination. As we all know that confirming an appendicitis, it could be it's always a clinical. So if you want to diagnose a patient, even in adults, it's a clinical, unless you will need the imaging for further confirmation. Before practice, my Dr. Mahmoud and other pediatric surgeons always mention, especially also in adults practice, that we go and if we see we palpate a patient, we can tell this patient can go to OT or not. We will start in palpation in the non-tender areas. Then we will palpate the right lower quadrant, the McBurney point. As we all know, we will see the tenderness is most there. Guarding, if we have a guarding, rebound, and pain when we are having a percussion. So this will go more with peritoneal inflammation. We can suspect this patient is having perforation maybe. Gentle pediatric maneuvers. Uh, Instead of deep palpation for the patients, especially the pediatric patient, this could be painful for them, irritating them so bad. So we can have a different kind of test as cough test, hop and jump test. Hop and jump test is good because you can ask the patient, for example, can you just jump? Can you just move on? You will see patient, as we mentioned, he is avoiding to do this kind of exercise or activity. So going with that, we will know this patient is in pain, this pediatric patient. We will avoid a kind of deep palpation, okay, and we can then palpate gently to see if to confirm this patient have a localized right lower quadrant pain or not. There are special signs, Rovsing sign, source sign, obturator sign, as we all know as also. But uh, this is important to mention. We don't rely on them a lot in pediatric groups. Maybe it's helpful in adult groups, yes, but in pediatric groups, we don't rely on them mostly in ER. So palpating will be the most important part. And if we have the hop jump test, it will be also useful. After talking about the physical examination, the clinical presentation, it's important to set now a differential diagnosis for a patient with right iliac fossa pain. So patient having right lower quadrant abdominal pain, but these are the more common from the most to least percentage, starting from this should be the first differential I should even confirm or rule out. Then we have a gastroenteritis, constipation, mesenteric adenitis, UTI, urinary tract infection. We have a gynecological causes as ovarian cyst. We have a mid-cycle pain, ectopic pregnancy, and uh, the other age when they start to get for the fertility aids. Okay, the renal ureteric colic, we have Crohn's disease, Meckel diverticulum, testicular torsions. But as we see, start from acute appendicitis 25 to 30% to testicular pain, which will be less than 1%. So in this presentation, we're going to focus on the most differentials we should think about with a patient presenting with right lower quadrant pain. First, mesenteric adenitis. So, mesenteric adenitis can be similar to appendicitis in what? Both will have a right lower quadrant pain. Both could have a fever, nausea and vomiting, and abdominal tenderness while palpating. But the difference will be this. When we are taking history, and this is the important, to rule out mesenteric adenitis or to think about or suspect mesenteric adenitis, there will be a recent upper respiratory tract infection. This means any pediatric patients present with right lower quadrant, you should ask about if he's having a recent upper respiratory tract infection or not. This is important. Other features, the pain will be more diffuse, and the age groups from 5 to 12 will be more commonly affected. Constipation. So yeah, there will be an abdominal pain, loss of appetite, nausea. The difference will be in presenting of hard stools, a pain after passing stool or flatus. There will be no fever. If we are having a constipation, there will be no fever because there is no a secondary bacterial infection. When you are talking about an appendicitis, it will be inflamed. There is an infection. So this is important to mention as well. When you are talking about the fever, don't please keep in mind that this will be a low-grade fever, not a high-grade fever in appendicitis. So yeah, early presentation for appendicitis will be in low-grade fever, not a high-grade fever. But yeah, this is a feature we can differentiate appendicitis and constipation. The pain improves after passing stool and flatus, as we mentioned. There is no fever and no migrates for the pain from the periumbilical to right lower quadrant. It will be diffused. It will be in the lower abdomen, okay, but it's not a localized in right lower quadrant abdominal. For the urinary tract infection, it will be similar to appendicitis in lower abdominal pain, fever. Patient could present with nausea or vomiting. It will be different with dysuria, frequency, urgency, and yes, positive urine analysis. We will not talk about the laboratory and the imaging in this slides, but yes, we can use them later to confirm and also to differentiate between UTI, for example, especially some presentations of appendix, as we mentioned, could present with suprapubic pains, which may misdiagnose you with be misdiagnosed with the UTI. So there is no a migration for the pain. Pain will not start in the periumbilical and go to the right lower quadrant. It will not be localized also in that area. Mid-cycle pain, or what we say it, Mittelschmerz. I don't know, it's German term. So yeah, similar for appendicitis and lower abdominal pain, both of them, but this is important. It's present in the right side, so right lower abdominal pain. This could be confused in a females. So in a females who will have, we should ask for mesenteric cycle for the old females, okay, around the evaluation when it start. We should take this history, sudden onset of it or not, because the mid-cycle pain will be a sudden onset. It will not start in the periumbilical and localized later on in there. There is no fever, no anorexia, no vomiting, and it will be a self-limiting, and this is important. Self-limiting for hours to 1 to 2 days. The appendicitis will be not a self-limiting. It will be in progression until it get perforation. Testicular torsion will be similar for the appendicitis in the lower abdominal. Nausea also and vomiting will be there. It will be different from appendicitis and patient coming with scrotal pain, swelling, high rediging testals, absent cremasteric reflex, scrotal examination will be abnormal. So This is also important in females, as you are asking about mesenteric history in the older female group and age groups. Yes, also you can ask about if you can examine and ask if the patient in males, if he is experiencing any testicular, any scrotal pain. If there is any swelling in the scrotum, this will be also important to rule out or to suspect testicular torsion. Finally, we have the renal colic, uteric colic. This will be similar for the right-sided, right flank abdominal pain, nausea, vomiting. The difference is the colicky pain. When you have renal colic, it will be a sharp, sudden pain. Not will be as the pain will not be the same as the appendicitis. Hematuria, pain could go to the groin, testis. Patient will be restless. Appendicitis patient usually lie still. At the end, and finally, as a take-home messages, we should maintain a high, we should maintain a high suspicion. Don't anchor on the classic triad. Don't always suspect that any patient with right lower quadrant, with appendicitis will present for me with right lower quadrant pain. It's wrong. We can have other presentation will be misdiagnosed. Many children with appendicitis do not have a textbook features. As we mentioned, especially below the 5 years patients. Sorry. Just drink water. Always remember to rule out the emergencies if you suspect other causes for the clinical presentation for the symptoms patient present with. When you have any doubt with patient with right iliac fossa pain, don't send the patient back to home, especially the pediatric patient, because the time limit of getting the appendix to get perforated will be less. So being in the hospital setting will be more in saving his life, especially if he is getting into complication. And always involve the pediatric surgeon early. Yes, which I think all of you, especially in ER, are doing, just to, it's a take-home message. These all was our references in this presentation. Sorry if my presentation was that long. Sorry if my voice wasn't clear. I was coughing at the end. Thank you all for listening. Anyone have any question, we will be happy to answer.
Thank you very much, Dr. Rali, for that comprehensive presentation. Dr. Mahmood, are you going to be taking on from here? What is the plan? And anybody has any questions, can please post them. Either unmute and speak or put it up in the chat.
Yeah, good morning. Thank you, Dr. Ali, for the good presentation. My question is, you are not mentioned about the symptoms of newborn, because newborns having appendicitis is not very common, or we are not heard much. But since you mentioned this many percentage, can you mention to us what will be the presentation?
Hello? Doctor,
Hello.
can you just repeat the, yeah. I was having a sound issue. Can you just repeat the?
Yeah, because you mentioned neonates also present with acute appendicitis. So how do we diagnose that? Because normally here we are not seen such cases so far. At least we are not diagnosed it properly. So how do we make it out if it is there in a newborn? How to diagnose?
You mean in the neonates?
Neonate.
Okay. Dr. Mahmoud, you will take over. You are mute.
Mahmoud, you have to unmute yourself. No, we can't. We still can't hear you, Dr. Mahmoud. You will have to unmute yourself.
Now I think you can hear me.
Yes, thank you.
Yeah. In fact, yeah, thank you for the question, Doctor. Actually, the appendicitis in neonates, we didn't cover this topic because, this is extremely rare. I don't have the exact, percentage, how many neonates among all the appendectomies we do. But from my experience, let me tell you, in Salmania, when I started my residency, till I became a consultant, till I go into retirement, maybe I have seen 1 or 2 cases, at most. So these are very rare age group for appendicitis to present. And as you said, since they are rare, then the diagnosis will be actually much more difficult because, in neonates, normally when they present late with complicated appendicitis, and the symptoms and signs will be, general symptoms. It won't be specific, like a child who's presenting with sepsis, abdominal distension, vomiting, and with peritonitis, let's say. Clinically, the child will have abdomen that is showing full picture of peritonitis, and then decision will be made, on a clinical data that we have on the clinical examination and labs and imaging. And most of, neonatal pathologies, when you have peritonitis, then you go for, finally, if you have, most of the time, the imaging will help us. Maybe ultrasound won't be easy to diagnose appendicitis in neonates because of the late presentation and spread of the pathology all over the abdomen. But CT scan will be extremely helpful in these cases and what will guide the surgeon for the pathology. But anyhow, most of these cases will present late, will present with general signs, with sepsis, with perforation, and they need laparotomy and for to treat the condition. Have you ever seen any, and I don't know, in your practice, anybody here has seen neonates with appendicitis? Those who are all the audience. Yes,
no, we are not seeing. How many percentage did you mention, Dr. Ali? Because neonates, you have mentioned a good percentage. That's why I asked that question. What percentage?
That was the risk of perforation, Dr. Mariam.
Perforation. See, perforation should happen only if it is
85%.
present. So the naturally, if it is present.
Perforation rate in neonates.
It's high, yeah. Perforation rate is high, but it's not the incidence here. Yes. Any other question?
Thank you.
So very often when we encounter a child with symptoms and signs suggestive of appendicitis, we get an ultrasound done. Before we get the ultrasound, I know we have POCUS, point of care ultrasound, and I would like Dr. Manita to share her experience on that.
To all IM first-line staff.
Yeah. What was it?
Let's give a break. Yeah.
Presented by Dr.
Yeah.
For me, the question wasn't clear. Can you just repeat it? I think.
Can you repeat the question?
Yeah, I'll repeat the question. There was this announcement that came up, so I had to pause. So when we encounter a child with signs and symptoms suggestive of appendicitis, and we get an ultrasound done, and the ultrasound is inconclusive. Very often that happens. That's inconclusive. But the symptoms and signs are quite
quite consistent with appendicitis.
Mm.
What is the next step? When do we go with just the clinical features and findings, or do we necessarily need to get a CT scan to confirm the diagnosis before you consider taking the child up for surgery?
Yeah, this is a nice question. Actually, we encounter such categories in which the patient present with the symptoms and signs of appendicitis, and the ultrasound is not clear or not consistent, with typical. So I think here, because see, one issue is the in the past when we used to practice surgery, I mean, we relied more on clinical symptoms and signs, and we didn't have the access for imaging. So, and many of these cases used to go for surgery. And in fact, we tell the parents that we accept a rate of 5%. In the past, actually, it was 5% negative appendectomies in these cases. And this was the clinical practice. Now, with the presence of the imaging techniques, and also because of the pressure by the parents, many parents will not rely on the clinical diagnosis or surgeon decision. They want to see to hear that an imaging has showed signs of appendicitis, okay, and this actually puts pressure on us, especially also with the presence of the insurance, cases. So in these cases, I think yes, medical legally, if you have a patient with clear clinical signs and symptoms with the ultrasound that is equivocal or not clear, then you have to go for CT, which is much more accurate. The other scenario that actually we face now, since you asked this question, is the opposite actually, in which a patient has present with early appendicitis, or with a condition that mimics appendicitis with very little signs and symptoms, and you send him for imaging, and this is common, I think, in your practice. And the radiologist will label this patient as early appendicitis based on some findings on the ultrasound. Actually, this also puts the patient, the surgeon, on pressure, whether to accept this case as appendicitis or not. I think, also in these cases, these patients, they need either, another imaging modality like CT scan, or what I prefer is to observe the child and do serial examination, because many of these cases will present with minimal signs and symptoms, with early signs of appendicitis on ultrasound. Now, we'll not go to details of ultrasound findings, but let's say early signs, appendix slightly distended. There is little signs of inflammation, otherwise no fluid collection, no ficcolith. So these patients, I think they deserve re-evaluation, observation and re-evaluation, because many of them, they improve, and you can safely discharge them at home with instructions to the parents that if pain recurs to come back to the emergency. So this category, I think, yes, we can just observe them and send them, either observe them in the hospital or at home, since many patients live very close to the hospitals, so they can come back again for re-evaluation. Yes.
Can I just follow up on Dr. Bramara's question? Since being an emergency physician, I've seen different practices with this. When do you think, Dr. Mahmoud, is the best stage to involve the pediatric surgeon? Is it when you have a clinical examination that is with increased likelihood of appendicitis, or after doing the ultrasound? Because some of these intermediate cases where you cannot prove it or you cannot rule it out, who has the burden of proving or ruling it out? Or is it the pediatrician, or is it the surgeon? Would you like the surgeon to be involved later stage when you have proven? I've seen different practices within different hospitals. Some of the hospitals will involve the pediatric surgeon very early on, as soon as they find right lower quadrant tenderness. And then they can arrange the further investigation, but the surgeon has to rule it out. But other hospitals, no, I've seen people waiting until the ultrasound is back and then involving the pediatric surgeon. When do you think is the best time to involve the pediatric surgeon?
Yeah, see, the classic teaching and the classic practice is, when the patient is received by emergency department, the pediatric emergency, they do the history and examination. Maybe they will do few labs, but in governmental hospitals where there's classic practice and classic teaching, so here the surgeon will be involved early before going to the imaging. So before the stage of imaging and after the history examination and let's say basic labs, the surgeon should be involved because the residents are there, the consultants are there are on-call doctors, so they are involved early, and they will direct actually the further evaluation of such cases in which they need imaging to confirm or not. But in the private practice, because we are not present there, and the residents are, most of them are general surgery residents. We don't have pediatric surgery residents whom you can really rely on their clinical examination and evaluation. So here we give little more chance for the pediatrician to decide whether this child really is highly suspected and imaging is deserved in this stage or not. So it depends on the location, on the training of the residents, the category of the residents available, general surgery residents, pediatric surgery residents. So all this will affect. But classic teaching, yes, I'll tell you, it's after emergency evaluation and basic labs, then surgeon should be involved. Pediatric surgery team should be involved, and they should direct the clinical, or clinical evaluation.
And these proportion of cases who have abdominal tenderness, but the ultrasound is inconclusive, do you think they should be best admitted under surgical care or under pediatric care to further exclude or include appendicitis?
Yeah, see, first of all, the question is whether we need to admit them or not. Here, actually, it depends on the clinical signs and symptoms. If the child doesn't have, very bad signs and symptoms, just mild pain, and child have little discomfort, many of them will tolerate oral intake. So I think even you can send them home and you bring them after a few hours of course, of observation in the hospital. After a few hours of observation, if the condition is the same, then you can send them home. And you can ask them to come after 6 hours or 8 hours or next day. Depends on the clinical. You teach them the clinical, the progress of the disease. And many of these patients are living very close to the hospitals, and they attend very early before the stage of perforation. So many of them, they'll go home. Some of them, those who need to be admitted, I think the same answer I will. It's the classic practice. If they need, we in Salmania, when I was we have in the pediatric surgery department, we admit them under our care. We admit them, we re-evaluate them. But in the private, I rather rely more on pediatric team, who I think are very good, and especially in American Mission, I think you have very good team. The consultants, the residents, they are most of these cases are admitted under the pediatrician, and we follow them. And along with, as a team, like ourselves and the pediatrician, and we follow them, and we decide based on the clinical signs and symptoms and progress of the disease. So in the private practice, I'll tell you, we'll continue the admission under pediatric team, and the clinical or the classical places like governmental hospital, they will be under the surgical team, of course.
Yeah, thank you, Dr. Mahmood. This is Dr. Sana. Just as a follow-up to that, because I know we're in the same chain. Of course, you know that the majority of our pediatricians are in the peripheral clinics, and we don't have the luxury of residents. And the surgeon also, we have a general surgeon, not a pediatric surgeon. So in this case, as you said, do basic labs plus ultrasound plus minus. So you'd like us to involve you after we get those two done, and of course our clinical diagnosis based on what we find. Is that what I gather from what you've said so far?
Yeah, in fact, most of these cases, doctor, what happens actually, they involve me early by telephone call. I get the clinical data from them and usually the results of the basics of the labs. Then based on that, actually, since I'm not present all the time, then I discuss the case with them and we decide whether this child needs imaging or not. Then after, if requires really my evaluation, I attend usually if I'm available. If not, then I ask them to do the imaging. And then I get involved after the imaging. So many of these cases, yeah, I think I can rely on our team. I have the confidence.
Sorry to interrupt here, but from what I understand from my experience, that the labs don't rule in or rule out appendicitis, right? So maybe involving you based on clinical examination would be better, and then guide us to do the ultrasound later. I mean, even on the phone, just to get the clinical gist on what is the examination. Is there a highly likelihood based on the clinical examination, right?
You are right, doctor. This is the issue. This is the limitation that we have in the private practice. I'm telling you, this is what we have. Since I am not available most of the time, I'm working as a part-timer. This is very, a special situation. And so in these cases, we prefer that to get full evaluation of the child and then get the surgical evaluation, surgical assessment. So this should be fine. Especially, I'll tell you, most of these cases, if you want to rule, as you said correctly, the labs will not, rule in or rule out the disease, but it is an important tool with the clinical assessment of the patient, history, examination, and the labs, along with the ultrasound. You have to put things together and then do the final decision. And don't forget that now with the insurance patients, we have a pressure by the insurance to do, if you don't do imaging, then they will ask, what is the ultrasound? You cannot take any sort of child to the theater without an imaging. Okay, and you can, even with the families nowadays, you cannot take a decision for this child has appendicitis or not without imaging. Now the families so many times they will come with the ultrasound where it is done somewhere, and then they will bring everything for you and they'll tell you, okay, this is the case. So because of the change in the practice, actually, I'll tell you, this is not the classical practice that should be done. It is not practiced in the governmental hospital, but in the private, most of these cases will come with everything, with the full labs, even unnecessary labs, okay, and imaging, and then it will be the role of the team to decide whether this is appendix or not. But as you said, the clinical examination by experienced surgeon or clinician is the best and most important a tool to rule in or out, to rule out the disease, appendicitis.
Yeah, thank you, doctor. Now we have, from the perspective of POCUS, which is point of care ultrasound, I would like Dr. Vanitha to share what is the incidence of, what is the rate of false negatives using POCUS. POCUS is getting more and more into clinical practice now. We don't wait for the sonologist. But then when compared to other imaging modalities, let's say an ultrasound by a trained radiologist, plus or minus a CT scan versus POCUS alone, where are we with respect to statistics with respect to false negatives? Dr. Vanitha, are you available?
I think she's not.
She's with the patient. I'm not sure she's there in the team. She's there in the.
I think.
Do you have your? Can you share your experience, Doctor Mahmood?
Yeah, I exactly. Yeah, for me, we have actually, as a surgeon, I always tell the residents and the students, as a surgeon, maybe our practice with the imaging is different than the pediatrician. Normally, when we order an ultrasound, at least either we go and with the radiologist if we are available, and we see the images and the study, so we see what the anatomy that we see during the surgery. So we see it as a black and white on the images on the screen, or at least if done, then we have to see the images and the findings that been mentioned in the report. So we don't rely just on reading reports. From my experience, again, this is same as we said, that since ultrasound is operator dependent. Now, whether it's focused or not focused, or what techniques they use, it all relies on the radiologist, how experienced he is, and how he looks for the findings. Many times, as you said, those who are trainees or starting their training, they can image something like a bowel or something else and report it as appendicitis or an appendix. So unless we see the images ourselves and we get very clear evidence that this is really what they have seen is appendix, and we correlate it with the clinical data that we have, then we don't just take these findings as a tool or indication to take the patient to surgery. Of course, some cases like imaging is very important in patients like in female patients, in which they present with ovarian torsion or some gynecological problems, and also in complicated appendicitis in the patients with appendicular abscess or let's say appendicular mass. So imaging will be extremely helpful in these cases. But in general, most of these cases, of course, clinical evaluation would be great and would be really the main direction, the tool directing toward the surgery or no surgery. I don't know, Dr. Benita is there just to comment on your question or not? I have a question for everybody. Do you use any scoring system? Because nowadays many studies or trials, they are talking about scoring system based on clinical signs and symptoms, and I think the labs, and they categorize the patients as low risk, moderate risk, or high risk. So anybody is using these tools because there are many scoring systems. I don't know how they are helpful in practice. I've never used them because these are very new, maybe new generation. They are using them, and also many studies show that they are. It's good only just to categorize the patients, to low or moderate or high risk of appendicitis or suspicion of appendicitis, but it's not really a good tool just to direct you to definitive treatment.
Yeah. I think Dr. Manita may not be available, but then just wanted to share this from online, from the net. This is what I gathered. They conclude that after doing a lot of meta-analysis, based on the findings of the systematic review and meta-analysis, it's reasonable to conclude that POCUS can be used as an effective tool to diagnose pediatric appendicitis. With a moderately high sensitivity, it may not be recommended to be used to exclude appendicitis based on POCUS findings alone. So you can't use it to exclude appendicitis, but to diagnose, yes. Further prospective studies evaluating the reliability of POCUS in excluding appendicitis, either alone or when combined with the clinical prediction rule, are required. Secondary findings from this study demonstrate that POCUS may result in a reduced length of stay in the pediatric emergency department and lead to a reduction in CT utilization, though insufficient data were available to draw firm conclusions related to this. So it does have a role to play in diagnosing, but completely excluding appendicitis is still doubtful. It cannot be used for that. And but it certainly helps in reducing the length of stay and probably reduce also the need to utilize CT scan. And like you said, if you're using these modern scores, I mean, at least I'm not using any modern score. I know Dr. Arafa had presented some time back, and he did present a scoring system based on which appendicitis diagnosis is made. But like you said, if there is any doubt, best is to keep the child in and observe.
Yeah, observe, exactly.
Observe. So I think all of that, this will help in observing the child, redoing the POCUS. And if it's very early appendicitis, and if it's actually turning inflammation, the inflammatory signs are present later on, a few hours later, then it helps in diagnosing appendicitis just by using POCUS.
Yeah.
Thank you.
I just wanted to add maybe the presentation of Dr. Ali. I didn't just comment on that. Thank you, Dr. Ali, for your presentation. Just I said it last. He mainly concentrated on the clinical part of that, signs and symptoms. I tried to avoid going to the labs and to the imaging, because there's another topic, and it needs a separate discussion maybe in the future. One important thing, or two important points that I wanted to highlight in the emergency evaluation of a child with the suspected appendicitis is the role of the analgesia. I don't know, maybe the residents are with us or not, but it's important for everybody to know that analgesia, maybe somebody will say it will modify, but I think based on the trials and studies, it doesn't modify the course of the disease. So you can use it, that you can give actual analgesia, perfalgan. That's what we do for a child who's coming with suspected appendicitis. In fact, this has also and it doesn't modify the signs. This is at one hand. On the other hand, it might improve actually your clinical examination, accuracy of clinical examination, because the child will be more comfortable during the examination, so you can elicit the signs. Especially that it's very difficult to get a cooperated child for the clinical examination. So analgesia can be used safely, and it doesn't have any change in the decision making in these cases. Another point is the antibiotic. The antibiotic is the opposite actually. IV antibiotics, especially, they can modify the clinical signs and symptoms. That's why we don't use antibiotics. We don't start them till we have till we confirm the diagnosis. And this is very obvious in our clinical practice. And once we confirm the diagnosis, start the antibiotic, we inform the parents. If the surgery will be done, for example, next day, we inform them the child will improve. This improvement doesn't mean that the disease has regressed. It means only improvement because of the antibiotic. So this should not change your clinical decision after that. And the parents should be aware of this. The last point that I wanted also to highlight is the category of patients who are presenting with non-specific abdominal pain. Nowadays, most of the kids, they are obese. They are having very bad dietary habits. They have constipation. And they present with, this is in my practice, with very strange abdominal signs and symptoms, Many of these cases, categories, because of this, I think the dietary changes and the habits, and also because of the build of the children and the obesity, this puts many of these cases who are having non-specific abdominal pains that are not surgical, they present to emergency, and they will mimic, sometimes appendicitis, and these cases will be challenging for the team to reach the diagnosis, proper clinical diagnosis, especially they are obese. And in obese children, the diagnosis will be very difficult. The history, most of these cases will not give a good history. Clinical examination won't be easy in an obese child. I think this is one of the indications that imaging would be really helpful in these cases. You cannot avoid imaging in these cases, especially if the signs and symptoms are present and the suspicion is there.
Thank you very much, doctor. Thank you very much for your inputs. And I hope all this will help the whole team in correctly diagnosing acute abdomen and referring at the right time, and all of this adding to patient safety and experience. Thank you very much. And we'll wait for the second session on imaging, and maybe then we can have more involvement of our focusins as well. It will be good to look at the labs and the radiology and CT scan and the focus. We'll take that up at a later time. Thank you very much again, Dr. Ali and Dr. Mahmood.
Thank you. Thank you.
Yeah.